Hi, everyone. Welcome back to Face It with Dr. G. I'm Dr. G, and I have the pleasure of having my dear friend and esteemed colleague, Dr. Julie Woodward, here with us today. She is so unique and so special in the field of aesthetics and the field of medicine. She is the chief of the Division of Oculofacial Plastic Surgery at Duke. She is both extremely academic, has published tons and tons of articles and textbook chapters, but also very involved in the aesthetic arena, speaking all over the nation and the world. So welcome. I'm happy to have you.
Thank you so much, Gretchen. I'm super excited to be here and just impressed with your whole practice and everything I've seen you do. You just kind of popped onto the scene a few years ago. I'm like, who is she? She's amazing. It's great.
Well, you are too, and I wanted you on here to, as I mentioned, to personally learn more about your journey, but I think it's fascinating what you've done and it's so unique. So, just to start, just tell us you're in medicine, but truly, you can give us the Cliff Notes version or you can give us the full version. How did you get into medicine?
So early on, I, believe it or not, thought I wanted to be a psychiatrist. And so I worked in a mental health hospital for 3 years during college, and that was enough to teach me I was not cut out to be a psychiatrist. I've always been an artist. I love working with my hands, and I really wanted to help people see because being an artist, I just appreciated vision so much. So I was fascinated with ophthalmology, always kind of intimidated by it. You know, a lot of people did research to try to get in, whereas I was kind of burned out after the first year of medical school. I went and taught English in Japan. Then I kind of came back around in a circle. I said, I'm really going to go for this ophthalmology. So got accepted to ophthalmology, loved it, loved doing cataract surgery and all those things. But within ophthalmology, the most artistic field to me was oculofacial surgery. And I loved aesthetics. I mean, I think one early piece of advice I got going into my career was from actually Brian Beisman, who I'm sure you know, Brian. He's a huge force in the aesthetic world. And he says, be honest with yourself. Don't try to put yourself like a round peg into a square hole. He says, just do what you really like. And I thought, you know, I really like aesthetics. Maybe people don't appreciate it and think it's a little bit cheesy and not real medicine. You're not taking care of cancer, but I liked it. So during residency, I was interested in oculofacial surgery. And then my chairman introduced me to Dr. Sterling Baker. And Sterling had really pioneered laser skin resurfacing in the early 1980s. He developed the first laser blepharoplasty in 1980 and laser skin resurfacing in like 1984, 85. And that was when they had to paint on the laser a 1 millimeter spot, one dot at a time, dot, dot, dot. And it took them 4 to 5 hours to do a full face laser, and it took them about 5 hours. So they would put people under general anesthesia. And then they later on in the 90s developed the computer pattern generators that we're all so familiar with now. But he knew how to take care of every complicated face, every complication. And I knew that's who I wanted to train with. So I did my fellowship with him. Wow. Then I was in private practice for 2 years in Houston. And then I came to Duke. And I've been here for 25 years.
Wow. So what made you transition from private practice back to academia? Because that's typically the reverse way.
Exactly. So that's another story. So I was at a hotel and I was listening. I wanted to go to this hotel to hear a talk about photofacials from Patrick Bitter Sr.
Oh, wow.
And I went to the hotel to listen to him speak about IPL. This must have been in 1997. And I was far more interested in the other speaker. And I didn't even know anything about him or anything he was speaking about. That was Sheldon Pinnell, speaking about vitamin C and SkinCeuticals. And I just thought that the antioxidant research that he did was so fascinating. So there was a little crowd of people waiting to speak to him after his talk. And it's one of those split-second decisions. It's like, well, I could just go home because it's an evening and I'm tired, or I could wait in line and meet him. And I did. And he told me all about this position at Duke. And I was at Duke about 4 months later.
Wow. Changed your life, literally.
Yes. Yeah, sometimes a quarter split second decision can change the entire path of your life. So yeah, I was one of the fastest people that they ever credentialed. And the reason I was interested in coming to Duke was our university is extremely forward thinking, and they built an aesthetic center, which almost no other university has. It's a freestanding building just for cash pay aesthetic procedures, and they built that in 1996.
Wow.
And at the time, they had CO2 lasers, a Pulse laser for tattoo removal. So I took care of all the tattoos at Duke. They had a vascular laser and lasers for hair removal. So I kind of walked into this little niche of getting to have all these cosmetic lasers because honestly, the dermatologists weren't that interested in it.
I
They
was going to
didn't
say,
want it.
was there pushback? How did they
Not a
develop
bit.
that? Not a bit. Wow.
They were excited to have me come on because Skip Burton, who's the big cosmetic dermatologist, he was tired of doing the tattoos. He wasn't that into the vasculars. He's like, let me show you how to use these lasers. They were happy to have me take them over.
They're like, here
So
you
for me,
go.
it was fun. Yeah, and believe it or not, when people had oh, what's his name? Hy- the cysts in
Oh,
the rear end. Yes,
hydrocele? Well, that's not
yes.
hydrocele.
No one would treat those cysts with laser hair removal except for me. So even though I'm an oculofacial surgeon, I was treating hairs around the anal area to help these poor people with these horrible cysts. I'm like, I really went into ophthalmology to stay above the neck. Somehow I ended up down here, but
You're
it
like,
worked out.
okay. As long as it doesn't become a full-time job,
That's
you'll do
right.
it.
And I love taking off the tattoos. I took off a lot of tattoos before the laser eventually died. And it was an interesting patient population. And getting to see the tattoos and help a lot of these people was a lot of fun.
Well, I'm sure you heard some interesting stories too, if they wanted to
Absolutely.
share why they had the tattoo
Yeah. Yeah.
and
So
why
that
it's
was kind
coming
of my
off now.
circuitous route to getting into academics. And so my little moral of the story to anybody interested in is just, just go with your heart and do what you like. I think it's much more accepted now to show interest in aesthetics than it was earlier on. It was almost a little bit taboo.
Totally. So you mentioned several things you said. You obviously are a lifelong learner and you crave knowledge and you want to know everything and your mind is open and you ask a lot of questions. Have you always been like that, or is it your parents that instilled that in you?
I think so. I think, yeah, certainly some of it is cultural. I think my dad's a scientist, and so he's always looking at creative ways to do research on Alzheimer's disease, effects of drugs and alcohol in the brain. He's a neurophysiologist, and my mother, she was very, very intelligent and she always fostered creativity in us. If we didn't like doing something, she didn't push it, but if we were interested in something, she fostered it.
I love that.
Yeah.
I love that. That is awesome. What types of activities did you do as a kid? Did you play any sports?
I was more of the artist.
Yeah.
So I think that's why I was so interested in surgery. I always was at ceramic class or calligraphy class, watercolor class. I did a lot of oil paintings. And actually during my residency, I sold quite a bit of art. And I had a gallery show and I sold every piece in the gallery. And from there, I got so much attention. I won first place in an art contest that had a whole bunch of artists. And then from there, I did a bunch of commissions. So it was more fun to do commissions because they were more personal and the gallery didn't take 50%. And so, yeah, I did all these terrific commissions and it was a lot of fun.
What kind
And
of
so I don't have
artwork?
time to do that so much now because I'm so busy and, kids and all that stuff. But during the
Yeah.
pandemic, I did get to do some art and I showed it down in Miami at the Miami Convention Center during one of the aesthetic meetings. Steve Diane had me bring my art down. It was really fun.
Oh, that's awesome. That's
Yeah.
so awesome. Probably VCS. I think I was
No,
VCS.
it was I think it was the Informa me. I can't remember which one it was. Yeah, down in Miami. It was during kind of when things started to loosen up with the pandemic. I was like, hey, I did all this art. So we shipped it down there because they were big pieces and
That is
it's fun.
awesome. Have you ever thought about doing illustrations for anatomy textbooks?
No, I think illustration is actually really different than art. Art is harder because you have to be creative. Illustrating is a little more cut and dry. It's like I see it, I draw it, I try to make it realistic. It's not as creative. I think it's harder to let your brain go with something more abstract or surreal than it is to do illustrations. But I love them both. So yeah.
Yeah, I agree with you. I agree with you. But
Yeah.
that's beautiful and fascinating. When it comes to your background, with everything about the eye, I always ask my patients when they're in the chair, what's your favorite feature? And I have my idea of what I think their favorite feature would be, but I let them speak. And I would have to say, 90% of the time, I think it's their eyes. And eyes are just beautiful. And what would you say would be kind of your go-to top three treatments, or do you have a plan for people how to make their eyes enhance? Is it a combination of neurotoxin? Is it temples? Is it under eyes? What do you do around the eyes to beautify them?
Well, of course, surgery is my thing.
Yes,
So,
and
I
surgery.
always start with people kind of top to bottom, systematic. I always start with the inside out and the top to the bottom. So when I'm doing a consultation, I go through their hairline to their brow, upper lids, lower lids, different things. And then I always talk about their skeleton because most patients don't realize how asymmetric we're all born. And so I have to talk to them about which orbit is a little bigger, which eyeball may be sitting forward or back a little bit more. And they always are kind of stunned. They're like, oh, I never thought about that. I'm like, well, did you ever notice that your ear is a little lower on that side? And so is your whole eyeball. So I always kind of just explain their own anatomy to them and let them know it's okay. It's normal. We're not ordering a CT scan or MRI scan. You're good. And so, of course, my favorite operation ever is blepharoplasty. Upper lid blepharoplasty is always a home run. It always makes people happy. And then, of course, lower lid blepharoplasty as well. I do all my surgeries like that with the laser. Okay. So I don't cut on my patients with a knife. That's what Sterling Baker created, was the laser blepharoplasty. I like it because it's rapid. It bleeds very little, so you can see the relevant anatomy. And I love it for sculpting fat pads. I think I can sculpt fat pads much better with a laser than other modalities. And then I don't have to change the shape of the lower lid by cutting and redraping and putting stitches in, which over time we sometimes see cicatricial ectropion in patients that have had that done. So we more uniformly tighten the skin in the lower lid with laser skin resurfacing. And it's just a great field. Patients are always happy. And then we do a lot of brow lifts as well. Obviously, a lot of full face lasers. I like fillers under the eyes, of course. Sometimes I do fat transfer. It just depends on the patients. And so it's a wonderful field. And yes, you're right. The eyes are the window to the soul. So I feel it's the most luxurious area of medicine to practice. I love it.
I agree. How would you say the temples affect the eyes? Because I feel that's something that patients don't often recognize, they've lost volume and they need some volume replacement. How do you deal with that?
Yeah. I think some patients, it's not an area they're used to looking at. And I think it's really nice to point it out to them as an option. Do you have to do temples to be beautiful? No, temples, some people look beautiful with a little bit of hollowness to their temple. A lot of the supermodels are so skinny, if you look at them, they all have a little bit of hollowness in their temples. But I think it's a really good option, especially for people who are starting to get too hollow. We're starting to see the back of the orbital rim and things like that. I think one trick that I do that's kind of off-label with temples are not just filling the hollow of the temple, but I like to oftentimes pull the hair out and fill under the hairline, because when you can create a more rounded silhouette instead of an indentation of dark hair against pale skin, when you can create it being a little bit more rounded like that, you don't have to use as much filler, but straight on you have a little bit nicer silhouette. And so I love doing that.
And what product do you typically choose for that? And are you deep? A deep bolus?
Usually just underneath the hair follicles, because I don't like to be so deep that I'm close to the parietal branch of the superficial temporal artery. But if you nick the bottom of the hair follicles, you can actually get a little inflammation, because I think sometimes there's a little bit of bacteria down in the hair follicles. So, and I sometimes will use a cannula, sometimes tiny little aliquots with a needle. But so fairly deep that you're just kind of hopefully between the vessel and the skin. I've never had a complication from doing that, so I'll just keep doing it the way I'm doing it.
I know there have been some reports of hair loss doing that, but you haven't.
They're probably getting into the artery. And so it's very important to always remember to inject perpendicular to the artery and to use tiny little aliquots, so that you're never cannulating and creating a column that's really knocking out that parietal branch, because that will go all the way up to the hairline right here. And we biopsy that artery quite often for superficial, for giant cell arteritis. You can biopsy the temporal branch or the parietal branch. I always go for the parietal branch. But it's hard to say what happens when somebody actually loses hair, because we cut that artery out all the time and it doesn't seem to make people lose hair. So it must be enough filler to percolate through into some of the smaller branches to have something like that happen.
Yeah, that makes sense. Makes sense. But it seems like a great treatment, and I have heard of it, and I know people do it, but I like your explanation, because I think people do it, but they don't really know what they're doing, and they don't, know possible sequelae. But
right.
Yeah.
So I've done a variety of fillers there. Of course, we know that, Volum is FDA approved for that area. I've also used Restylane Lift in that area. I think it's one of those areas where you can put anything there and it's going to work pretty well. So,
Yeah. Yeah. But obviously more of a higher G prime product
right.
to give you more of a lifting capacity.
Yeah.
Um, what would you say your typical schedule is? Well, what is your schedule? Because you are prolific with literature. Are you still publishing a lot? Are you doing a lot of research?
It kind of comes in waves, is sort of what you have time to do, and it also depends on your support. A lot of it depends on your fellow. You have a fellow that's really interested in writing, you're going to get more papers out, especially if you have creative ideas to push. I mean, you always have to come up with the idea for the research, and then the fellows, you got to hope they're going to run with it because you don't always have time to run with it. And not everybody wants to write papers, so yeah, sometimes and sometimes you can get a medical student that wants to run with it because they want to get a fellowship or they want to get into residency. And so those are kind of who you look for. And that's one nice thing about being at the university. It's so stimulating. We never get bored. The energy you get from having all these young people around really wanting to learn and develop their own careers, and you're helping them launch. Like, it's so exciting when you get someone into a good residency program. It's like you're giving them their life. I got a text from one of my fellows the other day. She's amazing. She just bought a building and she's so excited. She wanted me to come visit it. And I mean, I was like glowing all day long that my fellow had just purchased a building because, it's just so exciting.
Yeah, I do miss that. Just hearing you talk about it. There are nuances I don't love about academia because I think sometimes it breeds interesting personalities, but I love what you're saying. You're developing these young people, and you went through that journey and you're giving back, and how can I help you? And I want to grow and give you all the knowledge that I have and be there with them on this journey. I still keep in touch with, my attendings from residency, from fellowship, from everything. And it's so amazing.
And there's totally different ways to be creative with your practice. I mean, for me, it's academics. I mean, academics is very limiting in a lot of ways. It's, difficult to get new, whatever you need. Sometimes it's like pulling strings to get things, although they treat me pretty well. I'm very, very lucky that Duke respects me enough. They built me my own little private bubble 5 minutes from my house.
Oh,
it's like a med spa. We have an esthetician. I have 4 or 5 devices in the office. It's so wonderful. My quality of life is so good. Even though I may make a little bit less money being in academics, my trade-off is so big. I love it. But then you have things like look at how creative you are. You're on the circuit all the time. You have this podcast going, and then I mean, your office is exploding. You have all this staff. You're always like, my staff does that. My staff does that. My staff does that. I'm like, I don't want my staff to do anything like that. That's amazing.
Oh, yeah, we have an incredible team. I mean, it's taken years to build, but just hearing
you can be so proud of it. That's incredible.
Yeah, I'm proud. I'm very proud. I'm tired, but I'm proud. And I love what I do, but I think I started a mentorship program because I missed the smaller moments, right? I missed the building phase where it was much simpler, and I was actually involved in every piece of it. Now, be careful what you wish for, because director of operations and chief growth officer and da-di-da-di-da are running all the things. And I'm like, have I lost my purpose in life? What am I doing? Because the goal
you always wonder if the grass is greener on the other side. It's one of those things you just always wonder. And sometimes I get jealous of my friends that have more control over their practices that may be in private. But then I look at my situation, I'm like, I got a really nice deal. I'm really doing pretty good. So there's no perfect job.
No, but it's about, do you have time to do the things you truly love? And that, I'm such a creative visionary like you are, and I just love thinking of concepts and ideas, and I would love to be more prolific in writing, but I'm like, I don't have the time, and I want to write a book, which I've started, and
that's
all
amazing.
of these things, right, that I love to do. That's at the end of the day, that's all that matters, is you have to be happy.
Right. That's exactly right.
Yeah, and you have 3 kids. Tell us as much as you want about
that. I do. Yes. Raising 3 kids as you're a busy mom is definitely a challenge, but you make it work. I can tell, if I were to mentor young people now, what I would tell them is, don't worry about getting on those lecture circuits and all that stuff when your kids are little. I didn't sleep for 7 years. And, I didn't write any papers the first 7 years of my career. You kind of just finding your way. And then I think one of the turning points for me was, I wanted to be involved in academics, but you kind of don't really know where to start your niche, and you've already got that going. You're really good. But I think that we had it was when Dysport was launched. And I talked to a colleague of mine in private practice. I said, hey, let's do a little launch thing at Duke. And that was fun. So they gave us some product. We did live, and we had all these people trying to learn about it. And from there, I think it was Gail Durman invited me to a big meeting that they were having in Chicago, and I asked a few questions at the meeting, and I remember it was Fred Brandt and Michael Caine presenting, so a long time ago. And I asked some questions that weren't so stupid, and I got noticed, and so I got invited to a couple more meetings from there, and it just started snowballing. And then it gives you more ideas for more presentations, and you start taking your residents and fellows to the meetings, and it just starts to blossom on its own. So when young people are trying to get their careers rolling and they don't know where to start, I say first just go to a meeting. You may have to pay for it, and spend your own money attending, but then start submitting abstracts about anything you're doing. Just get yourself on a podium, and that gets the ball rolling. So once you can start getting out there, and then eventually you'll start to get to the point where industry starts to notice you because you're on enough podiums, even at your own expense, and then you'll start getting invited to do things, which is really fun.
Yeah, it is really fun. And I think there's a pro and a con side, right? And I think the pros are, yeah, you meet people, you learn from them, you get all of these ideas, you network and you grow and build yourself. And then the con is, what conferences do you go to? Where do you feel you can make your impact? Is it actually educational, or is it just frou-frou? Because I do think we're getting to a point where things are very jaded by pharmaceutical companies, and you don't know who to trust. And are they up there just saying this because the company's paying them to say it? I mean, how do you feel about that?
Yeah, definitely. I mean, we all love working with companies. I mean, it's not just what they pay us, it's our community, it's our friends, it's our chance to network and get to discuss ideas. I mean, sure, we're getting paid a little bit, but you know what? It's not as much as people think, because oftentimes it's barely a wash for the time out of your office.
Yeah.
And I'm sure you run a very expensive ship there. So, like, for you to take a day off and accept an industry payment, you're probably losing a lot of money. So I don't think it's all bad accepting money, but I just like being in the community and hearing different ideas and debates and things. And sometimes I'll go to meetings where I'm getting paid, and sometimes I go to meetings where I'm not getting paid. I think that I'm a little personally, I'm just a little bit tired of the really big meetings with a couple thousand people, because I feel like they're kind of overwhelming, and I spend more time walking around the hallways than I do getting to learn anything in a conference. I prefer the smaller, more intimate meetings, like ski meetings, where we got to hang out at A-Bound.
Yeah.
That's a fabulous. I love ski meetings. They're just the right size to learn a lot and not be overwhelmed by a big conference. I also prefer some of the international meetings. So I've spoken in Monaco. I've spoken at MCAS a few times. I'm hoping I might go back to MCAS this year. Next month, I'm going to the AMWC meeting in Medellin.
Oh, wow.
So super excited. Yeah, I'm going down there. John Martin invited me. Shino's going to be there. I think Ozza might be going. Can't remember. But international meetings are exciting because you can learn things that aren't yet in the United States. You feel like you're a little more cutting edge, and you hear different kinds of debates. It's pretty exciting.
I totally agree. I wasn't planning on going to MCAS. It's in January again. It's every January. I didn't go last year, but I've been multiple years in a row, and I haven't done Monaco, which is on my list.
I've only done Monaco once. Yeah, it's nice. It's a huge auditorium. I think my talk was in front of 1,200 people.
Wow.
Pretty big. But I personally don't like going to Monaco, because to me it's too far, because you got to take that extra flight to get down to Nice. And then once you're there, it's a bunch of fancy restaurant shops and casinos. That's not my deal.
Yeah.
So, but the meeting itself was fantastic. It is a really good meeting. It's just a little extra effort to get down there.
Yeah. Have you done any other international ones like CMAC or FACE or?
No, I have not been to those. So I'm trying to think of what else. No, I've been to MCAS several times.
Yeah, and that's kind of it's the biggest one. You're going to find something there.
It's just massive, and it's almost, you wonder if you're like standing in the middle of a fire hazard when everybody's trying to register for that meeting. But,
what do you typically speak on when you speak at the conferences?
Different things. I mean, sometimes it's surgery, sometimes it's lasers, sometimes it's skincare. Okay. So, and I'd say my meetings are kind of split between doing CME and doing, industry work as well. So I enjoy doing both. I learn both. So
that's awesome. I love that.
Yeah.
Have you ever done an ultrasound meeting? You should come to Face It. I would love to have you.
Is it really good? Do you do ultrasound there?
Yeah, so I love ultrasound, and have incorporated it into my practice, and all of my injectors are very good in growing with their use of ultrasound, but I just think it's fascinating. I think you would love it
Oh,
because
fantastic. I mean, I have an ultrasound. We just turned it on today, as a matter of fact, and
there
we
you go.
realized that it wouldn't work because Duke hadn't renewed the subscription. There's a yearly subscription for it, so I
Wait,
had to
is
send the
it
patient out. I felt so bad, but they felt bad and they approved it right away. So I think we'll be ready to go very soon. But
is
yeah,
it the Clarius ultrasound or which one is
yeah,
it? Yeah.
yeah,
So
it's
we have
hilarious.
Clarius and then we also have Mindray, and they're both great. Both offer very different technologies, and obviously one is hands-free, hands-held, and then the other one is not. Um,
Right.
but we use it every single day, and not just for, obviously not for complication management, because then it would sit in the corner and collect dust, but we use it for just anatomy knowledge and growing, especially younger injectors that are learning their anatomy. It's so amazing to reinforce that. Um, and just watching how products evolve over time. You think you're injecting them in one place, they're actually not there. And then so much
Right.
dissolving that we're so much more efficient with now. So we love it. It's
No,
really
that's
good.
great. That's great. Yeah,
Yeah.
I think several years ago, somebody invited me to speak at the face meeting when I had a conflict and I couldn't go, but I've heard it's fantastic. So
Yeah.
maybe one of these years.
Yeah. But the conference that I started is called Face It, and it's
Okay.
all ultrasound and anatomy. It's in October. I'll send you the info.
Is it
But
in Boston?
it's in Boston. Yeah.
Oh,
And we
fantastic. I have a
have
lot of friends at Mass Eye.
there you go. We can have a big
Yeah,
reunion.
that's
That'd
right.
be
I'll be
fun.
there.
Yeah, and we'll have the Claris and the Mind Ray, and it's hands on. It's great. So, for everybody listening, I'm sure
Yeah.
they know because I talk about it all the time.
Hey,
But
any excuse to come to Boston is
I
good with
think,
me.
yeah, it'd be great. So, what would you say in your life? Because obviously, we're in a field, specifically aesthetics, where there's a ton of different backgrounds, right? Medical backgrounds, nurses, PAs, NPs, MDs, and there's a select group of people that still think, oh, MDs, they went through so much training and it's so hard and blah blah blah. And of course, we went through a lot of rigorous training, and I love that I did that. But it was really hard. And what would you say was the hardest part of your training that changed you? What was the hardest thing you had to do in training, I guess?
Oh, well, I think the internship was the worst year of my life. Internship I don't think people realize how hard it is to work over 100 hours a week. And there's no mercy on it. You're just brain dead the whole time. I had two car accidents during my internship because I was so sleep deprived, had never had one driving before that or after that, just during the internship. It's brutal, and I really kind of hardly wish it on anyone. Residency's tough too. I mean, don't think ophthalmology is like a joke because it's just eyes. When you're on call for ophthalmology, you're up all night long most of the time when you're on call. So those years are really, really brutal. And it's frustrating for, I think the reason some of the MDs get upset is they feel like they've done so much work and then they come out and then these reimbursements coming out from the government, from Medicare, are so poor. I mean, I sometimes think about it. There's like surgeries that I can do that people really need, and I love doing it to help them. For example, enucleating an eye. Sometimes we have to take out an eye for, a trauma or an infection or something like that. That surgery that can take an hour and a half or so probably pays less than injecting 2 syringes of filler.
It's crazy.
And we know how long that takes. So yeah, there's really good, talented nurse injectors, PAs, and so forth, and they're making tons more money than people that went through medical school doing all these things, and they never dreamed that they'd be paid so poorly by these, by the reimbursements.
Yeah.
So I think it's not that people are resentful that they're doing it. They're talented. They're really, really good. I think it's just they're frustrated with their situation.
Yeah. Yeah, I would agree. And um, I just think going through residency and then into fellowship, you're just on this track where you're like, okay, I'm getting to an end. Like, I hope I like what I'm doing, but it's a certain type of life that I feel like I lived. It
You
seems
can't
like
get
another
off.
life.
You're
You
right.
can't get
I
off.
mean, there is no getting off once you get started. You cannot just quit a path to be an MD and say, "Oh, I think I'm tired of this. I'm going to go be a nurse." I mean, you can't do that.
No.
It's once you're on the path. I mean, you can practice medicine not being board certified. I mean, you look at Peter Attia.
Yeah.
He's doing really well. He did a couple years of his residency in general surgery, and he was smart enough to say this isn't worth it. I think
Yeah.
he's smarter than everybody. And so
Very
he went
smart.
into regenerative medicine, and he's got his niche, and he's obviously doing amazing. I like listening to his podcast; a lot of fun.
I know. He's
So
good.
yeah, I love his podcast. But very few people can do that.
I agree. Are you doing any functional medicine at Duke or no?
Not a lot. I'm very interested in it. I mean, I've been speaking at the regenerative medicine meetings. I'm actually the medical director for a skincare company. They asked me to be their medical director for a secretome company. And I said, why do you want me? I'm not a dermatologist. I mean, you can find someone better than me. I told them this for a couple of months. I said, no, we really like you to do it. I said, okay, well, I'll do it, but I don't want to have to deal with a conflict of interest on this one. I said, I'll do it for free. And they said, really, we'll pay you? I said, yeah. I said, I just want to kind of get involved in the space so I can, speak at some of the regenerative meetings. So I've been to Genesis twice now in the Tell All Tribune, and, we talk about a lot of regenerative medicine there. And I just think the whole field is fascinating. A lot of debates going on, as you know, about, secretomes, exosomes. It's completely illegal to inject these things. And then the PDRN and the PDGF. I mean, the debates, I'm just wide-eyed trying to figure out what's going on. What are your opinion on those things?
Yeah, so I'm a late acceptor to a lot of these things. I want to see the data. I want to see the clinical studies and all of that. I don't adopt things for this reason. There are always going to be side effects and adverse reactions, and if it's not FDA approved, I'm not going to inject it. Now we can use it topically, but I kind of sit to the side and watch and
Yeah, and then there's the people who hop on the bandwagon immediately, and they're the first to get out there, and they can't wait to say, I'm offering this in my practice, I'm cutting edge, I'm cool, and that's their patient population. I'm kind of like you. I'm a little conservative. I want to see if enough people are doing it and see what happens with approvals and things. Definitely. I in one of my lectures about ethics of regenerative medicine, one of my favorite things is like, I don't even know if you remember it. You may be too young to remember, but do you remember the Life cereal commercial with Mikey?
I know
And,
life
and
cereal,
they,
but I
they're
don't know
eating the
about the
cereal and they're
commercial.
like, no, you try it, you try it, you try it. No, let's give it to Mikey. And Mikey eats it. They're like, hey, look, he likes it. And then the other kids will try
No,
it.
I
So
don't know.
that's actually the longest running commercial of all time
Wow.
because it's about, these little boys looking at the baby brother saying, we're not going to try it till he tries it. And I think that's me.
I love that. And I
Yeah.
think I feel the same way. I want to see everyone hash it out and see who feels a certain way about certain things. And at the end of the day, yeah, these companies pay injectors to promote them when they're brand new. It doesn't mean the company's good or bad, but there is an incentive behind the scenes, and I want to know what are we dealing with here. And by the way, we also have things like PRF that we use in the office and things that we know work. Now, is something better? Maybe, but yeah, it takes me some time to kind of
Right.
get the ball
To,
rolling there.
to feel
But social media
comfortable
is
with it.
tough because it's being thrown in your face, and then my injectors get all excited and they want to bring it into the practice. I was like, okay, let's do our research.
Right.
Yeah.
Yeah.
So for
So it's
me,
a
I
crazy
just,
world out there, and I think there's a lot of debate that's going to be happening. We hope some clinical trials come out of it. I think that would be great. So,
yeah. Yeah, it's just the same with all the fillers. There's so many different brands. They're all HA based. What makes them different? Why do we use one versus another? And at the end of the day, you're just going to start confusing your patients. Why this or this? You want to be careful and make sure you're offering products and services that you believe in and you can fully recommend.
right. And I respect industry because everybody's got a job to do. Their
Oh,
job is
of
to sell their
course.
fillers. Unfortunately, I think that industry over pushed a lot of indications in very large volumes. And I think that's why there's this kind of backlash against fillers right now. I think fillers in appropriate doses are amazing.
Agree.
I never over injected my patients. I've always had a patient population that wants to look really natural. And for me to inject more than two syringes, honestly, on day one is kind of unusual.
Yeah.
I usually start people off low and slow, add a little bit on at a time. And I have a I don't deal with a lot of edema under the eyes, like a lot of people that have overfilled. But then I see these people that are put on podiums and their standard is 10 syringes on day one. And I'm like, really?
Yeah.
So it just
It's
depends
a
on what
lot.
people are comfortable with. I mean, everybody's got different styles and different patient populations, and depending on what part of the country they live in and so forth. So,
Yeah. And it's fascinating to watch how the tiniest bit of filler affects other areas of the face. I mean, it's nice to see the gradual progression. And yes, it absorbs a lot of water after the fact. So why are we going to slam the face full of product? You're destroying the architecture immediately. So I completely agree with you. And I mean, I love the skin health treatments, radiofrequency microneedling, just putting these all together to create beauty that is long term, not okay. I mean, 10 syringes of HA filler in the face, you're going to have swelling. You are going to become dysmorphic.
And it's not immediate. That's what's
And
the
it's not
problem is
immediate.
people don't realize this. It's not that month or even that 6 months. I mean, that edema doesn't start for about 2 years.
Yep.
And if they keep going in thinking they're going to look better by pumping it up more and more, there's this mentality from patients that if I spend more money, I'm going to look better. But sometimes you need to spend less money to look better.
Yeah.
And I'm just a very conservative person in general. I know what I'm going to get a good result with and what I'm not.
Right. And they'll look at your face and you're absolutely beautiful and you're not overfilled, and people care. They'll look at you and say, okay, I trust her or I trust him.
But I do tell patients I have no idea what I'd look like without filler in my face. That I've got it everywhere.
I do say this whole thing is
I am
fake,
so
but if you
fake.
like it, yes. But I don't know. Have you heard of this study by Leonie Schelke? It's called the SMILE study. And essentially it's about the overfilled facial syndrome, overfilled syndrome.
Yeah.
And what happens is patients notice that their smile changes at first. And right, they're getting wide and we're continuing to add and build and becoming so wide. And they say, I look completely different, but my eyes look different. And
Right.
she did a study where she measured different areas of the face and how the smile changed when filler was placed into the SMAS. And essentially with ultrasound guidance, specifically dissolving that HA that's in the SMAS, because it's connecting all the facial muscles, immediately changes the smile and the eyes open up and everything. So the ways that you can have just those how the animation changes with too much HA and in the wrong plane, it's fascinating. And I've been dissolving
Right.
a ton of it.
Yeah. Well, it makes sense,
Yeah.
Yeah, and I saw a patient today that had filler in so many places, and I thought she looked pretty good, but I was shocked at the records and how much filler she had injected in different places in her face. I was like, wow, it's a lot of filler. And so something's going to happen eventually. If it's not now, how many times have you seen a global inflammatory response in a patient? Have you seen that before?
I have. I just dealt with one a couple of months ago. She came over from Martha's Vineyard and was desperate, whole face completely distorted.
Yeah, completely. I mean, like a boom, giant inflammation, and yeah. And there's always something that triggers it. Anything that triggers the immune system. And I've had that happen to a few patients that have come in. These people have no problem with filler for many, many years, and one day they get a sinus infection or a UTI or a cut on their leg, and all of a sudden, poof, filler can just explode everywhere. Fortunately is a very uncommon thing, but it's
devastating. I mean, she was desperate.
Yeah.
Completely desperate, and other people, derms in New York, all over, did a great job trying to manage it, throwing the kitchen sink at her. But at the end of the day, you have to get rid of the HA. Now, you don't have to get rid of all of it,
yeah,
but you have to get rid of the HA, or it's not going to go away. And they had pounded her with hyaluronidase, antibiotics, steroids, this and that. She'd wean off the steroids; they would rev back up again. And so we did several rounds of ultrasound guided dissolving, and she's been
doing good.
asymptomatic.
Yeah, I had my very first case of that. I think I had was probably about 15 years ago. It was a long time.
Wow.
Oh yeah, the first time I ever saw this, I had a patient that had been injected with HA for 4 years. So it was mostly our tried and true Restylane because that was approved in 2003. So this must have happened, maybe 2008 or 9, somewhere in there. And whole face exploded. One round of steroids, completely recurred. And the only thing she presented with was droopy upper eyelids, just a little bit of ptosis like this.
Wow.
And I was like, why did she have that? I thought it was a sinus infection. Gave her some antibiotics, didn't go away. Got a CT scan. I'm so sorry, my dog's barking.
Oh, that's okay.
Got a CT scan, clear sinus. I was like, whoa. And then all of a sudden the whole face blew up and I put a test on her arm and that exploded. So we did 2 rounds of oral steroids, nothing. But finally had to put this patient into the hospital, high dose IV steroids.
Wow.
And then she had to stay on oral for an entire month. And it finally calmed down. And then, of course, she went elsewhere and had other fillers that were not HA injected. So that's what everybody always wants it back. That's the amazing thing
wants it back. Yeah.
Everybody wants it back.
Yeah. And then I had another recent case of a patient who had HA under her eyes. It was causing, edema, swelling, whatever. And wanted to dissolve. So had it dissolved. There was no allergy test done for the hyaluronidase, but she did have a allergy to bees, which it's not, it's very low chance that you're going to have cross reactivity, but she had an allergy to bees. So she gets her under eye dissolved and leaves the office. It was by a plastic surgeon. Leaves the office, goes and has lunch. She has some food allergies, but didn't eat anything she was allergic to. The eye swells up in a huge hive. She starts freaking out, says that her throat's itchy, her tongue
Wow.
is swollen, all of this, but she does have anxiety as well, and does have the bee allergy. Long story short, she came to me and he was like, "What can you do for her? The plastic surgeon is my friend. What can you do for her?" I was like, "Well, if I went with your notes and just assumed what you said, and she has an allergy and now she's diagnosed with an allergy to hyaluronidase, so we can't dissolve her, I guess I would be at a dead end." But I don't, not that I don't trust him, but I question everything and I redo it on my own. So we did a hyaluronidase
Okay.
test. She was fine. She came in, she pre-medicated with Benadryl. Totally fine.
That's great.
So
Yeah.
it wasn't a true allergy, and I think you just have to question. You question why things happen, question why things are done. Is that a true allergy? Is it not? Think of the story. If it was a true allergy, she's not going to have a hive 2 hours
I
later
think it's
after
so
being
rare to be
injected.
allergic to hyaluronidase. I've only
So
talked to
rare.
one person who was convinced they had a patient who was allergic to it when they dissolved filler in their lips. Huge reaction. But I'm
Well,
like,
but
how do
you
you
can
know it
get
wasn't a
that huge swelling after Hylenex
Ex-
is
Exactly. I
injected.
said, how do you know it's not small breakdown products of the hyaluronic acid happening? Because I've probably injected 20,000 blepharoplasties by now with hyaluronidase. I
Mm.
mean, we use it in every single blepharoplasty. We put hyaluronidase in there. I've used Widase, Amphidase, Vitrase, and now we've been using recombinant, Hylenex for a really long time. I've never seen any remote reaction to it. Not to say it's not possible.
Yeah.
And then I was at a conference once. I think it was LAMCA, and it was me and Bob Goldberg and Wendy Lee and Jennifer Burdock. We were all combining the number of blepharoplasties that we thought we had injected with hyaluronidase, and we decided that between all of us in that room, it was 100,000 blephs with hyaluronidase, and no one had ever seen a reaction.
Yeah.
So, of
Very
course, it's
rare.
possible, but I think that cumulatively, we think it's very safe.
Yeah, I would agree. We should do a case report on, well, I was just thinking the two cases, the one with your global swelling and mine. We could do a fun case report on that. People need to see these
Yeah,
things,
yeah,
you know?
yeah,
But
definitely. Yeah, and I don't think there's enough written about the global inflammatory responses,
yeah,
but
no, I agree.
def,
But this has
yeah,
been awesome. I could talk to you forever. Um, I am so happy to have you. We can even do part two and just keep going. But thank you so much. And thank you for sharing your insights, obviously, about you personally and about your journey. And where can people follow you or find you on social?
I do have an Instagram page. The universities don't like us to be really vocal on it, so we have to be careful. We're not allowed to put patients on it. We're not supposed to put a photo really technically being on the campus, although the residents and fellows do it sometimes. So it's at Dr. Julie Woodward, no punctuation, no capitals, at Dr. Julie Woodward.
Love it. Perfect. And thank you again. And to all of you watching, please like, share, subscribe, and we'll see you again next time.